Good morning, and thank you so much, Pascal. I'm actor number 1. I think we're 3 of them coming along. And I hope in this talk this morning, I'm able to share a lot of good updates and positive hope in this environment where we are 20 years later from where we started, or I should say 24 years ago from where we started to where we are today. These are my disclosures. And this is the timeline of what I'm going to speak about, really from natural history to newborn screening, but just in terms of what's going on in the US, because Dr. Chen is going to speak about much longer term experience. So just from where we had started, I think in terms of infantile Pompe and the spectrum of disease, I think the focus is just those who have cardiac involvement. And I want us to rewind and rethink that there is a spectrum even in infantile Pompe from classic to non-classic, and by which I mean from the most severe to yet severe but less severe, death within the first 2 years of life to those who can survive beyond 2 years of life, and then along those lines, the most extreme phenotype, which is CRIM negative, and then the gradations of CRIM positive infantile Pompe disease. And I'll come to the terminology of CRIM in a few minutes. And so this is the study that was done in collaboration with many of you in this room, which clearly showed that infantile Pompe disease is lethal and that we have a median age of death in our infants by 8.7 months of age. But the key message here is that not everyone was succumbing in the first year or the first 2 years of life. And the little boy to the right is a reminder of what was then described by Dr. Al Slonim as non-classic infantile, where there is presentation in the first year of life with cardiomyopathy, but this little boy was alive even at 4 years of age at the time of which enzyme replacement therapy was initiated. So these historic slides, I think, are really a reminder of how the field started when we were initiating clinical trials. And at the time, the clinical development map was first the natural history studies, then the clinical trials, and then, of course, doing the studies in adults with Pompe disease that Dr. van der Ploeg will be speaking about, and the learnings from there. So in that first study, again, a reminder to ourselves of the lessons that we have learned. The first study had 18 babies and the second study had 21 babies. The difference between the two studies was that the second study involved babies that were more involved. They could be on a ventilator at the time where they were started on the enzyme replacement therapy. And in the first study, which was the 18 babies, they were all less than 6 months of age and they were not on any kind of invasive ventilator support. Also, as a reminder, in that first study, there were 2 dose groups that were used, 20 milligrams per kilogram and 40 milligrams per kilogram every 2 weeks. All this, I think, is going to ring through the next 1.5 days, but to say that some lessons have been learned. So what did we learn from study 1, which was the pivotal trial? At the end of 52 weeks, where you see that arrow going down, what was learned was that 100% of the babies were alive. And then as we followed these children out for a longer time, we realize now that we lost some children, and now 72% of them were alive. But clearly, this was very different than the natural history, which was that babies would be deceased by 2 years of age. So a complete landmark change in the natural history as enzyme replacement therapy was on the horizon for Pompe disease. And again, these are videos depicting examples of children, even in that first pivotal study. Again, another reminder that just because you start at a certain age, it does not mean that your response to therapy is going to be the same. Some ended up being walkers, and then there were some that were alive, but as you can see, were not really achieving many motor milestones. So I think that this first trial taught us a lot. And then we realized and learned that the heart was a star player. You can see that within 12 weeks of enzyme treatment, there was a significant reduction in the heart size. But this first pivotal trial, or these first 2 trials, taught us that if you started at a younger age or stage, your risk of death was decreased. If you started at that younger age, your risk of invasive ventilation or death, so a higher bar, was also decreased. We also learned that the heart, which was the key player, actually you had a better response when you started when you were at an earlier stage of the disease. So I think these first trials, as we look back now in retrospect, did give us a lot of insights into the disease. And these publications are really from collaborations from around the world, gave us information about babies up to the first 4 years of life. So what really happened after clinical trials and after the approval of this FDA-approved treatment, which is known as either IV Myozyme or IV Lumazyme throughout the world, is I think where we are here. So we learned that a multidisciplinary team approach is needed. Guidelines were developed for Pompe disease, and these were done globally. I'm just sharing examples in the interest of time. And there were also physical therapy and a number of other guidelines in terms of diagnosis for Pompe disease. So where we came from 2006 when the drug was approved to where we are today is the understanding of many factors, the new treatment history that's emerging, the limitations and challenges of enzyme treatment, and of course a new era today where we are, which is newborn screening for Pompe disease. So once again, in terms of the factors which are affecting the response to enzyme, I think I already talked to you about the age and stage of the patient. We also learned that it also could depend on the muscle fiber type that the individual had, a predominance of type 1 versus type 2. The dysregulation or autophagic processes, which Dr. Rabin was the pioneer in. The role of other genes that could play a role, like certain changes in a gene that could impact how your response to therapy could be. Antibody issues to it. And then, of course, there's dose also, which does play a role in terms of how children can do. So this was from the first set of trials, and you can see the before and after, that if you start, all these dark purplish dots are all glycogen. If you don't have as much buildup of it, then at the end of, say, a year of treatment, when you are to repeat a biopsy, you have much more clearance of the glycogen, which you see. But if you start more involved, then despite treatment, the impact of therapy is not going to be as good. So I think we understand this. We also understood this at the level of electron microscopy, that if you have the glycogen outside the lysosomes, which is what we see here, the enzyme really cannot be targeted to the site, or it will not act in that region. So key message and key learning was we're trying to get our individuals or our patients at a point where there is a salvage mechanism in terms of intralysosomal glycogen that can be cleared. And during that time, Beth Thurberg, who was at Enzyme, developed a very nice computer morphometric system where you could actually quantitate and measure the glycogen under the microscope. So a lot of learnings that I think are going to play a role as we advance. We also did learn that although the heart is a star player, that the response was not uniform, especially in terms of the heart rhythm disturbances on the conduction system of the heart, that glycogen still remains there. So once again, a key learning that we need to follow our children longer, and some of them can develop arrhythmias or heart rhythm disturbances over a period of time. So whilst we definitely have an improvement in the heart size, we still have a risk of running this risk for arrhythmias. And then as we started to see our children more, we learned that with treatment, growth is very good. We learned that from a pulmonary status that they do well on enzyme treatment, but yet there are challenges. We learned from a motor perspective that many of them walk but do require ambulation devices. But what we also did learn is that there are some areas that are persistent in terms of weakness, in terms of the neck flexor weakness, a limitation in the ability of the child to move their lower extremities, and I'll show you pictures of that, and that there is a new emerging phenotype, which is not just adult onset or late onset Pompe disease. There are similarities, but there are differences. But I think an early lesson that we learned through these clinical trials and through our learnings is that if you started someone, what we then called early, that was less than 6 months of age, and those who were not on invasive ventilation, and those who did not make antibodies to the enzyme treatment, those are the ones that actually survived and did well. So these are some common features that I think are having application as we move ahead. But here's to show you the persistence of some of the features that we see. The neck flexor weakness in our children, which is also what we see in adults with Pompe disease. You see a lot of cuteness, but you can miss it. You also see that they have the difficulty with climbing or with getting up from the lying down position, so similar to what we see in adults with Pompe disease. We do see some differences in gait. I want you to pay attention. We see this foot slapping gait, which was work that was first identified. I have to give credit to Laura Case from our group, where you can see this foot slapping gait difference from what we see in adults with Pompe disease. And then we learned that they have weakness in terms of dorsiflexion. So you can see that the children cannot really dorsiflex or raise their feet up as we could see in adults. So clearly understanding that there are similarities but there are differences, and these are important as we go into the next decade of learning because of therapeutic options. We also learned that there can be sphincter involvement in terms of bladder and bowel involvement in children with Pompe disease. And here, unfortunately, what you see is lack of sphincter, anal sphincter tone in advanced cases with Pompe disease. And so one more area that can be used towards learning of how we can improve if we had a new therapy or a decrease or an increase in the dose of the therapy. And so our lessons really have been multisystemic involvement in Pompe disease through this time of learning. Then comes the next chapter, which is the understanding of antibodies and CRIM negative to CRIM positive. And I think today we have advances where we can predict CRIM status by underlying genotype or mutations that Dr. Reuser spoke about. But in situations where it's unknown, one can do it through a skin biopsy or one can do it through blood testing as a way to tell if a person is CRIM positive or CRIM negative. And the reason why this is important is because your response to the treatment is different if you are CRIM negative. So when you see a band, it's telling us that there's some protein that's made that's CRIM positive. If there's no band that's seen, there's no protein that's CRIM negative. Again, historically, this is from the first clinical trial, lessons that were learned, that if you are CRIM negative and you make an antibody response, despite enzyme treatment, you do not do well. And so I think Baby John taught us a lot of lessons through the decades of how we can improve outcome. And if you're CRIM positive and do not make antibodies, you have a much more robust response to enzyme replacement therapy. And so different groups have used different regimens, but the idea is you've got to tackle the immune system and prevent that antibody response. This is something that we had developed or put together at Duke. And our experience now on 26 of the most vulnerable babies who are CRIM negative has shown us that if you pre-treat at the time of enzyme replacement therapy with these agents, then 81% of these cases you're able to prevent an antibody response. And in the remaining 19% of cases, if you go back with these agents or with additional agents, you're still able to tolerize them. And with that, what we've learned is that you're changing the natural course now of treated Pompe disease for CRIM negative, whereas where these babies would have all succumbed to the disease because of an antibody response, you now have children that are living longer as compared to those who were CRIM negative who would have died despite enzyme replacement therapy. And so where are we today? So these are from the original clinical trials, 2 children, and they are here today. You can see grown up, both are in college. One is in a wheelchair though, and one is still ambulating. So we do see a difference in terms of their long-term outcomes. And the next step is also to understand what's going on at the level of the diaphragm, which we know is very involved in Pompe disease, but we've not had a chance to study this very thoroughly in children because infant PFTs cannot be done. So this is a study from Dr. May from our group, who's our pulmonologist. And here we were able to show that children with Pompe disease who were able to do the lung function test, and again a reminder, all these children were now on 40 milligrams per kilogram per week of the enzyme, so not on standard dose enzyme treatment. At last assessment, the point to make is that yes, there is clearly diaphragm involvement, which we knew, but now we are able to show that there is a difference between the upright and the supine PFTs as we measure it by forced vital capacity in children with Pompe disease. And yet there are some children, if you look at the graphs, who are remaining stable, but then there are some who are having a loss in terms of their ability from a pulmonary status. Again, factors that are not very clear but need to be further understood. And I think the big elephant in the room today is the nervous system involvement and how, if it does, impact cognition. And so we are learning a lot through autopsy data, through clinical data, through collaborative research, through imaging studies of the brain. And I think at this point, there is no clear connection between central nervous system involvement and the cognitive functional outcomes. There is some emergence of challenges in the field, but the jury is not completely out. And so I think we have to be careful as we talk to our families about the central nervous system involvement in Pompe disease. So this is work from Gail Spear-Digliosi from our group. And essentially what she was able to show that even in the children up to 17 years of age, they're attending school, they're now going to college, and that some of the challenges of how we are testing for them. So for instance, patients who have below average academic skills can demonstrate average non-verbal cognitive ability. So the point to make is if you test them in a way which is difficult for them, we're not going to have the right ability to test, and that the lower performance on the IQ and academic tests can reflect a learning disability, not necessarily a low overall IQ. And then when we look at the literature on central nervous system involvement, I think this is information that we've had from autopsies, that there is glycogen accumulation in the brain. There is clinical data on the nervous system involvement in terms of the foot slapping gait, the sensory neural hearing loss, the bulbar weakness. So these are emerging. And now what is also emerging is the finding of the white matter changes. And this is work from Dr. Van der Ploeg's group showing white matter changes in the brain of children who are surviving. This is data from our group also showing white matter changes. But I think what we still have to understand is the progression. What is the meaning of this progression? And as a next step, what we have done is try to look at a scoring system, which is called the Fazika scale. This scale has been used in other conditions, but this is a quantitative way that we believe that we can track white matter changes over time. And we've selected 10 regions of the brain. This is based on published literature and our data of regions that are involved in the brain. And we've come up with an aggregate score of 30 because it's scored from 0 to 3. So the higher the score, the more the white matter involvement. So the point to make here is that there is a variation in the extent of white matter involvement in the brains of our children, the long-term survivors. We don't have a clear understanding how to predict who's going to develop it and what the significance of it is. But I think what we are learning, and this is again through collaborative learning, is that there are certain parts which seem to be involved first, and then there's a spreading to other parts of the brain. How this is going to affect our learning is going to be understanding this mechanism so that we can try and follow this more closely. And the bottom line is that we need more studies to understand this extent of central nervous system involvement in Pompe disease. And I want to close on a very high note. Pompe disease is on the RUSP, or the Recommended Uniform Screening Panel for Newborns in the US. Today, we have 20 states in the US that are screening for Pompe disease. And what we've learned is I'm trying to go to the most extreme phenotype, the CRIM-negative babies. There are 4 that we have heard about and learned about that have been picked up now by newborn screening. And so if you give the chance of life and chance of early therapy, I just want to tell you that these children are doing way better than those who were clinically identified. And so this is really showing us the overall survival, the red line here of CRIM-negative who have been picked up by newborn screening and have also received immune modulation. These are those who have been picked up clinically and have also been treated with immune modulation. And so the drop-off is children who we've lost through the journey. And this is those who were treated with enzyme replacement therapy alone, where we clearly were losing these children because of an antibody response. And so I just want to show you this video of a 1-day-old picked up who's CRIM-negative, who's treated with immune modulation. This is her at 2 months of age. This is her at 3 months of age. Note that she does not have a head lag. This is her at 2.5 years of age. And this is her at 3.5 years of age. So I think we've come a long way in terms of making progress in the field, where with collaborative and collective learning and early diagnosis, we can definitely change the course of this disease. Yet we've got a lot of work ahead of us. I want to remind us we've made a lot of progress to date. Pompe disease is no longer a lethal disease. Many of our infants are now in college, in school, and doing well. There are many factors that we've learned and are being addressed. We've recognized that there's a need for next generation therapies. We recognize that there's a need for understanding of central nervous system involvement and therapies that target the central nervous system and other sites that are not as responsive to the current version of enzyme therapy, but to leave us with knowing that the future is bright for our children with Pompe disease. And I want to thank my many collaborators in our group at Duke, the multiple collaborators across the globe, and of course, our global community of physicians, members from the FDA, and of course, also Dr. Rabin, who's here with us. Thank you.